Hi, this is Brian Kim. I'm going to share with you case number 281 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a patient who was referred for cataract surgery, and this patient has 16 cuts of radial keratotomy. And when you have that many very narrow pizza slices in the cornea, it's very difficult to make a clear corneal incision. Of course, it's ill-advised because it can intersect with those incisions, the arcane incisions. You're going to see me perform a scleral tunnel incision and then perform phaco through the scleral tunnel incision and then close that incision up with some sutures. And again, the angle of approach is very different when you're doing scleral tunnel cataract surgery, and that is the reason why this referral was made. So I like to ink the conjunctiva when I do the perotomy so that I can identify the cut edges of the conjunctiva so I can better approximate the conjunctiva when I'm done with the case. Do the perotomy and then a little bit of cautery. And this is the crescent blade. I'm going to make an incision about 3 millimeters posterior to the limbus. And the nice thing about a metal blade, you can control and titrate the pressure. By controlling the pressure, it actually controls the extent of your dissection. So this is the wiggle maneuver, which I've learned from our M6 colleagues. And this is a very important technique to know. Once I make my incision, I go ahead and make my paracentesis incisions with my 1 millimeter diamond blade, first on the left and then the right. This is intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium. And once I've inflated the eye, I go back with the crescent blade and I was able to penetrate through and I go in all the way. And then I switched with my Microrhexis forceps. And again, the angle is quite different because I'm lower to the iris plane. And so because of that, you just have to be mindful of the different angle. When you're coming from a lower approach, you're not coming from above, you're coming almost fairly parallel. And so be mindful of your technique and how you have to adjust it. But thankfully with this Microrhexis forceps through Moria, it's an excellent forceps. It gives me excellent control. You can see I have my dispersive viscoelastic cannula in my left hand. And if I encounter any trouble with chamber stability, I can push some more viscoelastic simultaneously as I do the rhexis. And you can see excellent control, good chamber stability. These Microrhexis forceps have a great tip that coaps very nicely. And I'm able to grab the capsule material very easily without any trouble. And so this is a Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, get a nice wave, lift the lens up, and then decompress the bag. I'm separating underneath the anterior capsule edge, and then the lens begins to spin. Right here, I'm trying to make sure there's no iris prolapse because I am close to the iris plane here with the scleral incision, and so I am burping some viscoelastic from the main incision. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Gently inserting the phaco tip, trying to avoid the iris tissue there. Turn on irrigation, go in with the chopper, remove the surface epinuclear material. Sliding the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, fracturing the lens in half. That is the double chop. Again, no ultrasonic energy or vacuum used. Placing the chopper under the right heminucleus, pulling it centrally toward the phaco tip and fracturing it against the phaco tip, and that is the cross chop. Turning the lens and doing the same maneuver, placing the chopper around the lens, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip with another cross chop maneuver, and then another cross chop maneuver. Observe the outlay on the right side. No ultrasonic energy or aspiration or vacuum is used when I am fracturing the lens into smaller pieces. Once I'm ready to eat the pieces, you saw I used the chopper to lift that fragment up and then emulsify the lens pieces. Grabbing that other fragment with some vacuum, crushing it with the chopper, and then emulsifying it. Lifting the second quadrant up with some vacuum, and then crushing it with the instruments, and then emulsifying the lens pieces. This Veritas machine has excellent purchasing power, so I never struggle to grab the lens pieces up and pulling them out of the bag. Some other machines, unfortunately, as you try to do that, the piece will just slip off the tip, and then you have to figure out another way to get the piece up. I've been so accustomed to using the chopper to pull the lens pieces up out of the bag, which is a very good technique, but it's certainly much nicer when you have a machine that can consistently help you pull the piece out of the bag because of excellent purchasing power, which is a reflection of excellent aspiration and vacuum, and the way the design of and with the design of the tip and the Phaco machine. So I have this hard nugget in the middle now, and I'm using my instruments to crush the lens. Again, flanking the lens with the instruments and crushing it between my instruments. Again, this is a manual mechanical fracturing concept. And once I'm ready to emulsify, you see I initiate aspiration vacuum and then pulse it with some ultrasonic energy as well. And so this is the final quadrant. I gently slide the chopper under the Rexis edge contra-incisionally, pull it centrally toward the Phaco tip and crushing the lens with another cross-chop maneuver, and then crushing it between the instruments and then emulsifying the lens pieces. Again, I'm so used to using this, crushing it with instruments, that it's hard to get out of that habit. Because this viscoelastic is so good and the machine is so efficient, I could really be more aggressive. So I take the chopper out, push BSS in, very gently take the Phaco tip out by turning off infusion first because I don't want that iris to come out. Go in with the INA handpiece. You can see there's some nuggets that were trapped within the incision. And then I grasp it with the INA tip and then mashing that lens material with the cannula. Starting with the Cortex mode, I start subincisionally, peeling side to side tangentially. This loosens up the cortical material. And then going on the other side, grasping the cortex from the anterior component and then peeling side to side. Switching to polish mode, polishing under the Rexis edge. And then using the cannula to pulse bursts of BSS into the subincisional space, which loosens up that cortical material. So I turn off infusion and then push some cohesive viscoelastic to fill the bag. And then I sweep under the Rexis edge with the sweeper, first on the left side and then the right side. And remember, when you push that cohesive viscoelastic, you don't want to be too aggressive, because if you do that, you might get iris prolapse. You see I'm burping some of that viscoelastic using the sweeper through that paracentesis incision because I really want to decompress the eye as much as possible. And then I go in with the lens. And as I go in, I'm making sure that the lens is clear of the iris. The injector is clear of the iris. And then I inject a single piece of acrylic lens into the bag. And then using the cannula that I had in my left hand, I go ahead and try to disengage the haptics from the optic. And this is a toric lens, so it's important for me to align this lens to the appropriate axis. Again, underneath the lens, remove the viscoelastic from within the bag. Polishing under the rhexis edge. Removing all the viscoelastic from the anterior chamber. You can see all the bubbles coating the corneal surface, the endothelial surface, and that is because this dispersive viscoelastic does a really nice job in coating the corneal endothelium, and that's the reason why there's really clear corneas postoperatively with this viscoelastic. So I go to low mag and try to align this lens using the narrow blade axis ring. You can see all those pizza pie cuts in the cornea. Again, there's no way you can make a main cataract incision through a clear corneal approach, and that is why we made the scleral tunnel. Using the Lester, I'm just trying to rotate this lens a little bit more, and then checking the alignment once again. And that's it. So I'm going to close the main incision with an 8/0 vicryl suture, the scleral incision, and then reapproximating the conjunctiva with the same 8/0 vicryl suture. And so that is the end of the case. So again, this is a patient with a fairly dense cataract, 16 cut RK. The patient was referred because they knew that this couldn't be done through a clear corneal incision. So I did a scleral tunnel approach, again, utilizing the techniques I learned with M6. You want to make a groove and then tunnel through the scleral tissue and wiggling, and you saw the way I did it. Enter, and then again, the approach is very different. The angles for Capsulorhexis, Hydrodissection, Phacoemulsification, even the lens placement is very, very different when you're doing a scleral tunnel technique. But it's important for you to be able to know how to do this. Why? Because this is not going to be the only person who comes in with this. You might have a 16 cut RK, a 32 cut RK. You might have a patient with some unusual corneal anatomy, and you need to be approaching it from a scleral side. What if it's a really small eye? Who knows? And so it's important to be able to perform scleral tunnel techniques, scleral surgical techniques, scleral incisional techniques when it comes to cataract surgery to help you take care of all patients, not just certain types of patients. So I hope this was helpful to you, and I thank you for your attention.